Good morning and welcome to our presentation of the On My Way first episode Psychosis program. We're glad to have you here today. My name is Cindy Griezak and I'm the Director of Managed Care Operations for Bucks County. I've worked as part of a team that includes our partners from Child and Family Focus and Magellan Behavioral Health to bring this important program to Bucks County's youth and young adults. During the pandemic, we saw a concerning increase in young adults experiencing psychosis across our levels of care within the children's mental health system, and we knew we needed to respond. Over the past several years, the Office of Mental Health and Substance Abuse Services has prioritized and supported first episode psychosis programming across the state. And through grant funding, we've been able to launch our programming with those dedicated funds. And today, you'll learn directly from the program and model experts on how to identify youth and young adults who are experiencing their first psychotic episode, what the model is and how it works, and how an early intervention, team-based support and treatment can lead to better outcomes for our youth and young adults. Thank you for being on and here today, and thank you for all your efforts that you do every day in serving our community. Before we move forward with the presentation, I ask that you put your name, your organizational role, and agency in the chat so that the presenters have a better feeling for the audience. As we move forward in the presentations, please also put any questions you have in the chat, and the presenters will respond when both the presentations have been completed. So with that, at this time, I'll hand it over to Dr. Sigler from Magellan to get us started. Dr. Sigler?
Thank you very much. Good morning, everyone. I want to start our informational session today by talking a little bit about what first episode psychosis is. To accomplish that, I just want to go over what is psychosis and talk a little bit about psychosis in children, adolescents, and young adults. The relationship between psychosis in first episode psychosis, particularly in adolescents and young adults with trauma and substance use. I want to talk briefly about the concept of a psychosis prodrome, which is a condition that can exist before a first psychotic break in a person that ultimately experiences psychosis, and why comprehensive treatment matters, why rapid, intensive treatment at the first episode matters, how it impacts a person's opportunity for recovery and for a meaningful life. Okay, next slide, please. Okay, so what is psychosis? A fancy definition would be conditions that affect the mind where there has been some loss of contact with the reality. And when a person becomes ill in this way, it is called a psychotic episode. During a period of psychosis, the person's thoughts and perceptions are disturbed, and the individual may have difficulty understanding what is real and what is not. This usually becomes evident first to persons that work with the individual, on a regular basis. Parents, as well as teachers or individuals that care for the person in an institutional setting, may first notice, that's really strange, the way they respond to this or respond to that. Next slide, please. So some of the behavioral warning signs are listed up here in terms of changes that we might see in the person. That would be an indicator that maybe something is going on that requires a referral to the first episode program. And as you look at these indicators, many of them overlap with indicators for other types of problems that youth may experience. However, when you look at the preponderance of these warning signs, we can see that if we have factors that include difficulty telling reality from fantasy, or, really and overly unusual, overly intense new ideas, strange feelings, paranoia. In the old days, the thinking used to be, we'll give them the treatment as usual for kids that are having emotional disturbance. And then, even though we might have some suspicion there might be psychosis, we're not going to go down that road right now because that's a really bad outcome. No, if we have suspicions about that, we want to go down that road now. That's the new thinking, because if that's what we can determine is going on, we want to start treatment as soon as possible. Next slide, please. Okay, so psychosis in children, adolescents, and young adults can be broken down into a couple of different criteria. Okay, some psychotic experiences, I want to say this first, may be entirely related to substance abuse. Now, when I say that, a lot of people that I've talked to in the past think, oh, so what you're saying is they're psychotic because they're using drugs, and as soon as the drugs wear off, the psychosis will go away. Well, and I might say, well, kind of, sort of. It could be entirely a phenomenon related to the drug interaction with the brain, but it could also be that this is a person who is vulnerable to psychosis, and the use of the drugs is I think the phrase we'd use on the street might be tipping them over into a psychotic state, and their vulnerability to psychosis will continue until the person stops using those substances altogether. Individuals can be prone to psychosis due to everything from certain prescription drugs, stimulants, street drugs, cannabis, K2, and other synthetic cannabinoids. Incidence rates for psychosis are also known to be higher in populations that are living in poverty, minority ethnic status, and living in urban city environments. The reason for this is unclear, but our incidence rates show that those are some characteristics that we see. Next slide, please. Okay, so childhood onset psychosis, what I mean by that is situations where we see psychosis like prior to the age of 13. Okay, and this is extremely rare. Psychosis or schizophrenia is extremely rare to begin with, and the legitimate childhood onset schizophrenia is 50 times less likely than schizophrenia. Now, what we do know is that more than 8% of children that are healthy have been reported to have some hallucination-like events at some point during development. But these are transient, and they go away, for lack of a better word. They don't cause significant functional impairment. There have been some large studies of childhood onset psychosis, and many of the children, the hundreds of children that were referred for that study, were able to be screened out as typically being individuals that didn't really manifest a severity of psychotic symptoms and functional impairment that would qualify. So we're still interested in seeing those kids referred, but primary focus of the program that we're here to talk about today is children that are 14 years and up that are experiencing psychotic symptoms. Next slide, please. Okay, so trauma-related psychosis. I'm showing you here is that we, have situations where kids have been exposed to a lot of trauma, and they may have in what we call intrusive experiences, which are flashbacks or dissociation, and that 82% of children who present with psychotic symptoms have significant trauma exposure. We also know that treatment of trauma can eliminate psychotic symptoms in 33% of kids who present with them. So we also like to incorporate trauma-informed CBT approaches, both exposure and non-exposure forms of treatment in a response to adolescent onset psychosis. One of the ways that we can discriminate between the two, and I've been told not to get into the weeds on this, but we generally see less disorganized thinking, fewer negative symptoms, and other types of problems with less fluctuating insight and so forth. Next slide, please. Okay, so high risk or prodromal state symptoms that we sometimes see with individuals are that they have symptoms that appear psychotic-like, that are transient or fluctuating, like they seem to be there and then later the person may seem more grounded in reality. They also may experience sensory illusions, experiences of where they feel like they're dissociated, or that they're experiencing something but they feel like they're not really there. Functional decline, or what we call negative symptoms, not taking care of oneself, not being motivated to do things that they used to do. Mood, anxiety symptoms are very common, as well as substance use and difficulty with attention and academic performance. Next slide, please. Okay, so why focus on first episode? What we know is that the whole focus is to shorten the period of untreated psychosis. Untreated psychosis has a negative and lasting effect on overall brain function. And when we can intervene quickly and decrease the period of untreated psychosis, we can increase the potential for recovery of function. And it can have effective long-term management. Next slide, please. Okay, so what you're going to hear about next is you're going to hear from Mr. Dan Fisher, who's the clinical director for an FEP program, and he's going to talk more about what the program is, how it works, and some of the main ideas. Thank you very much for your kind attention. I'll turn it over now to you, Dan.
Thanks, Dr. Siegler. That was very informative, and thank you. I think more importantly, approachable and understandable, because psychosis can be something that is highly stigmatized, and a part of this program and a part of any kind of coordinated specialty care approach is to reduce stigma so that we can better serve our young people who are experiencing their first episode of psychosis. I'm really excited to be able to present to you all today in an effort to further educate the child serving system about what psychosis actually looks like, and when to reach out for support from us On My Way. So today I'll be kind of going over the services that we offer. I'll reiterate some of the things Dr. Siegler talked about as far as, what does psychosis look like, especially from the standpoint of, loved ones to the helpers in our community. What can they look for, and when should they reach out to me for guidance? I'll also go over what the coordinated specialty care model is, which is the national model that all of us first episode psychosis programs follow, not only in the state but in the country, and where this all started, which was over in Europe, which they're about 20 years ahead of us. Going to go over the very important members of my teams that help serve these young people and their families. I'm going to talk to you all about the eligibility criteria for the program. The eligibility criteria is fairly specific. And so it's important to understand those as you're making a referral. So, but one thing that I'm hoping to present to you all today is that if you're not quite sure, that's okay. Try to give me a call and I'll set you up with either one of my intake specialists or call or speak myself. So if we could go to the next slide, that would be great. One of my favorite things about the program ever was I actually started this program in Delaware County back in 2016. And when I was first learning about what is the first episode psychosis program, I was deep into the literature. My background is in experimental psychology, so I hit the literature hard and learned about psychosis, and I learned about the coordinated specialty care model and all of the evaluation that goes into this program. But one of my county administrators said, I think that you need to have a little bit more of a recovery approach in your learning process. So I paired up with a certified peer specialist here in my county, Delaware County, and who experienced schizophrenia himself. And he, as a side gig, is a great graphic designer. So I learned a lot from him already, and some of it was, hey, I don't think you should call your program a first episode psychosis program, because I don't think young people will want to enroll in something where psychosis is right on the name. So we came up with the name On My Way, which is a recovery oriented, just a positive step forward so that we can, be on our way. And I had just had my youngest daughter, and I was watching Sesame Street all the time. And a lot of the times I would say, on my way. Anyways, so that's where it came from. A part of the coordinated specialty care model is that we offer a whole bunch of services and it's highly guided by the young person's voice and choice, and with their family as well. We are a community-based program. We go to the young people, except for when they come in for psychiatric services. For the most part, we go to them unless a young person says, you know what, I feel better receiving services in the office. Then we support them in getting here, which is really good. And typically in our high intensity program, which is what all of our young people enter into, they will be in that program for 2 years. Your Bucks County program has just started in the past few months. So eventually, after a couple of years, we will start to offer a step down option called My Way Forward. And that is similar to what I'm about to go over, except for with less intensity. And my dream is someday is to serve prodromal young people in the lower intensity one. And thanks to Dr. Siegler, you have a better understanding of what the prodrome may look like. So, yeah, I read my mind. I see that there are individuals on the call that may serve more than just Bucks County. So if you hear of young people in any of these communities, this is where we're located. For Bucks County specifically, we're opening a brand new office in Southampton. I'm pretty partial to it. It's kind of a beautiful office, and our young people so far have really enjoyed it. So if you want to take a screenshot of that, that's where our locations are. You can go to the next slide, please, listen. So Dr. Siegler already went over, what does psychosis look like? What are some of the symptoms? And, very basically, if you hear of young people sharing that they're hearing voices, or that they're having odd or bizarre ideas that are not grounded in reality, which are delusions, those are two of the most common positive symptoms of psychosis that we hear. Psychosis is kind of broken down into negative symptoms and positive symptoms. You can think of positive symptoms as the things that are added to your experience. So hearing voices, having delusional thoughts, thought disorder, and negative symptoms, which for our young people, especially ones 15 to 18, can be the most debilitating, and the ones that are also mirror things, mood disorders and depression. And those are kind of withdrawal from friendships, withdrawal from family, withdrawal from things that they used to love to do, a decrease in their ability to pay attention. You might see a decrease in their hygiene and at school, and overall, the negative symptoms are actually what we hone in on the most On My Way in the treatment that we do. So if any of your staff during supervision say, I have someone who has completely withdrawn from their life, or hearing voices, or having delusional thought content, it might be a good idea to think about On My Way. Dr. Siegler also talked about how substance use for specific kinds of drugs can elicit a psychotic episode, and that is very true. The way that we conceptualize a first episode psychosis elicited by a substance is, well, we don't know if that psychosis is going to happen again or not, or if they have a genetic predisposition towards schizophrenia or any of the schizophrenia spectrum disorders. That may have been the conversion to experiencing psychosis from now on. And our standpoint is, yeah, maybe it is a isolated event, but we don't know. So let's go ahead and start to work with them. And hopefully, maybe they just had a really bad trip from something like mushrooms or acid, or they smoked too much weed, which is something that the young people are doing a lot of these days with what is available to them. And so I know a lot of the times families will be like, well, we think it was just because he did drugs, and that's kind of hopeful thinking on their behalf. And so kind of getting them on board with, we don't know if this is something that's going to be sustained for a long time, or if it was just an isolated event. So it's best just to reach out to us for a consultation. Next slide, please. I've already kind of touched on this. The coordinated specialty care is, it's a model where we provide services that kind of meet all of the young person's needs. We're basically an agency all wrapped up into one program, an entire mental health system, and it's all right there at their fingertips. And so the main reason why the federal government has provided these funds for us to begin a lot of these programs is because what they were seeing was, if you can treat psychosis early on, then the trajectory of recovery goes back to the trajectory, or not quite, but close to the trajectory that they were on prior to their first episode of psychosis. It also helps to prevent the long-term consequences of untreated psychosis, and basically the way in which it can kind of tax the whole mental health system, where people end up going into long-term treatment facilities. This whole thing, the whole purpose of this program is to decrease the duration of untreated psychosis, to get people back onto the road to recovery so that they can have friends, have family, have work, and live their lives. And a lot of my young people will say, we'll talk about, what are your goals? What do you want to do? And they're like, I kind of just want my life back. I want my dreams back and all that. And so that's kind of what we do. We help young people get back to what they're supposed to be doing. You can change the slide. So when a young person comes into the program, they have access to a psychiatrist or a nurse practitioner who will provide them a psychological or a psychiatric evaluation at intake, and then moving forward, they will meet with their prescriber twice per month. This is a highly collaborative portion of our program, because we want the young person to have all the say in their medication choices. We want to know all of the side effects that they're having. We want to talk through any kind of resistance that they might have to taking the medication that the prescriber is offering. A very common thing with young people is, I don't want to take medication. I'm young, I'm okay, there's nothing wrong with me. So this is a highly collaborative experience that they have with our prescribers. They have great working relationships with the young people and their families. The families are a critical part to working with the psychiatrist. So they also have access to a recovery-oriented counselor, or what we call the ROC. They are the young people's ROC for sure. They are their number one contact within this program. They meet with them sometimes weekly, sometimes more than weekly, and they are the ones that they spend the most time with in this program. A recovery-oriented counselor uses the therapeutic approach called recovery-oriented cognitive therapy, which was created by Dr. Aaron T. Beck at the Beck Institute. It's basically CBT for psychosis, and it's just a really great person-centered approach to getting young people focused on aspirations and setting goals that will aid in their recovery. And to make it real easy, we want to focus on the young person getting busy, because when you're busy, the positive symptoms of psychosis subside, and you're also hitting the goals of whatever a young person wants to do, which is the most fascinating part about this. The young people that we work with we already have close to 10 in Bucks County, and all of them are amazing. And all of them have aspirations that are fantastic, just like a lot of young people. And so the recovery-oriented counselor helps them all the time towards working towards their aspirations. They also use CBT and motivational interviewing to prop up those aspirations. But our number one modality is recovery-oriented cognitive therapy. And we get consultation from one of the founding members of that program, which is a really great experience for our therapist. Now, everyone else on the program continues to do recovery-oriented cognitive therapy as the number one modality for the way they help them. But a case manager can help our young people get MA if they don't have MA quite yet. Work on packets that they might need. Some of our young people have housing needs. They would get help that from the case manager, CRR packets, some of those things, transportation to med visits, whatever. Certified peer support. In Bucks County, we have a straight up superstar for a CPS who had presentations at NAMI in Bucks County, and he's just doing really great work already in your county. And then supported education and employment services. This is a evidence-based practice, and they do exactly what that shows. For our younger kids, they want to focus on education, so we can pair up with schools. We can help them if they need a GED, we can help them with that. For the older ones who want work or need help with being successful in employment, resume building, interviewing, everything like that, this is their go-to, the supported education and employment specialist. You can go forward. So to be in the program, the young people need to be between the ages of 15 and 30 years old. And we also need to have the first episode of Psychosis to be within the past 18 months. So this is one of the more difficult portions of this program, I would say, and why Dr. Siegler and I want to be able to help educate the entire system about what psychosis looks like, because it's absolutely necessary for us to identify them within the first 18 months to 2 years. But the goal and like the dream would be for Bucks County residents who are experiencing their first episode of psychosis to start receiving treatment within 4 weeks. That's like the pie in the sky goal. One day is to be able to serve young people as they are having their first episode. So one thing to keep in mind, don't take first episode to be too literally. Okay, we're actually looking at the first about year and a half of them experiencing it. And so when you refer, our intake specialists will go in, and that's one of the first things that they're trying to determine is how long have they actually been experiencing psychosis. For everybody, it's different. For young people, every single one of them explains their symptoms of psychosis differently. And so the eligibility process with us is fairly intense and sometimes takes a few interviews to establish a true timeline. This next part's not completely true. Can you go back for a second? So in Bucks County, we still have grant money, or we're fully grant funded right now until we're open with Magellan, but so they need to at least be eligible, which basically means that they have a mental health diagnosis. Of course, it's a little bit more complicated for our young people who are over 18 who don't have medical assistance yet, but we've been able to get everybody medical assistance eventually. So I think more importantly, and something I'm missing here is young people who are experiencing symptoms of psychosis that also have autism. Autism cannot be the primary diagnosis when they're coming into this program, and to help, I mean, they need to have an IQ over 70, and yeah, so if anybody's treated autism and psychosis, it gets pretty muddled up and really hard to disentangle. And they may benefit more from behavioral type services as opposed to our precognitive services. So, some people on this call have already talked to me about young people who have autism and psychosis, and I'm not, there's not like a clear line on what the right answer is, but very basically they need to have an IQ over 70. They cannot, the primary diagnosis cannot be autism, and anything from moderate to severe would be exclusionary criteria. I'm sure we can have more questions about that. And then you can move forward. I think that hits them all. If you happen to be in the southern counties in Delco and Chester, Jen Nyland is your person to go to. If you have any kind of questions about members in Bucks, Lehigh, or Northampton, you can contact me. And there's my information. So if you want to take a cell phone picture of that or something, that's good. And when you reach out to us, we're basically just going to have a conversation with you about what's going on with the young person. And in our heads, we're going to be listening for positive symptoms and timelines and some of the other eligibility criteria. And we would go on from there. Next slide. Heads Up is our training and technical assistance partner based out of the University of Pennsylvania. That website right there has a ton of great resources on understanding psychosis better, understanding the coordinated specialty care model better, and overall just a wonderful place for resources, especially if you want to get some resources to have out so that young people can learn about them. We have Heads Up stuff all over our offices. And then, of course, NIMH is another good place to learn more. So that was a lot, but we have lots of time for questions. And I'm happy to try to answer some.
Just going over some questions that came through the chat. Someone asked, do you have any resources for the youth who come from Montgomery County? The shelter often serves other counties.
Alyssa, can you ask that one more time? I didn't hear you very well.
Somebody had asked a question if there's any resources for youth who come from Montgomery County that the shelter often for counties.
Yeah, so as of right now, Montgomery County does not have a first episode psychosis program. I know they're in talks with Heads Up when Montgomery County residents call me, I usually point them in the direction of the clinic-based first episode psychosis program, which is at the University of Pennsylvania, and it is called PERC, P-E-R-C. The downside to that one is that they have to travel into the city to receive their services.
I
There's
think
one
it's
more
also,
question in the chat, just asking about sharing the PowerPoint, that information if we are slides along.
one other thing I'd say about the Montgomery County question is Montgomery County is earnestly in the process of trying to understand the need for their county residents. So it's probably also important to share, if you're anyone on this call who's aware of that need, who has a counterpart in Montgomery County, like if you're servicing Montgomery County members in the shelter, to make sure you share that might have this need, make sure you share that with Montgomery County as well.
Yeah, Montgomery County certainly has the population to support a first episode psychosis program. And so like when you're doing like some population type determination of whether or not it can support a program, we're looking at 600,000 people or more. And actually Dr. Siegler gave some cool stats about, you know, what percentage of the population will actually experience psychosis. And actually 3% of the population will experience psychosis. Only 1% of it will become persistent enough to be called something like schizophrenia. So a lot of people experience psychosis. Like when I first had my kids, I would take a shower and I would hear them yelling, and my wife would say, "Nobody's yelling." You know, it just happens.
I think most parents, sleep-deprived parents, can relate to that one.
Like, you've been working in your program too long.
And another question came in, does PERC have the same criteria around when the psychosis started at 18 months? And does PERC accept MA?
I think PERC is actually 2 years. And I don't know if they accept MA. They probably do. They have a great website, and they always have somebody ready to talk to you. So.
We'll have a little bit more time for questions if anybody has any that's coming to mind. If not, you can always outreach myself, Dan, Dr. Siegler, try to get your questions answered.
I have a question, if I'm allowed. This is kind of like how to get it done question. So, and this is based on my prior experience in wearing a different hat. If a young person is living outside their family home, like they're in some kind of a setting, either through children and youth, or through probation services, what should someone do, like if they're in a caregiving role for that person, and they have concerns? What's the process that they should follow?
So anybody can make a referral to On My Way. We get self-referrals, we get referrals from CYS, JPO, across all of the 5 different counties. The best thing to do is to reach out to us if you have concerns about the person that you're caregiving for, and then kind of if they are accepted into our program, it's imperative to try to support them through the process, because our program is fairly intense. You're going to see the doc twice a month. You're going to see the therapist 2 or 3 times a month, you're going to see the case manager, the sport education and employment specialist, and the certified peer specialist several times a month. And it, a lot of the times the young people that we're serving are hard to engage and, hard to stay compliant with. So we're going to be trying to partner with whoever we can in that young person's life to ensure that we're getting all of the time with them that we can, so that we can establish a healthy recovery plan. So I think the best thing is to support that young person as they're learning their own recovery process.
Another question came through the chat. Dan, do you have other documentation requirements such as a psych eval within a certain period of time or IQ testing?
So if during intake for IQ question, a lot of the times we can just find it on an IEP. But the psych eval, a lot of the times we're getting psych evals from a hospital because they've been hospitalized due to their psychosis. But no, we do like them to have some sort of diagnosis coming in and some kind of clinical collateral that we can try to make the right decision with. Because when we're doing our eligibility checks, we're talking to the young person, their support system, if they have clinical people in their lives, we're trying to get all of the clinical information about them so that we can make the best choice possible. We want to make sure that they benefit from this intense program. And actually a psych eval, they'll get a psych eval after they've been enrolled into the program within the first 2 weeks. So there's not a specific requirement that I need a psych eval. That was a long answer for a short answer.
Yeah. Oh, I have a related question. It's always easier when the person has significant problems and they're hospitalized and a psychiatrist has already made a decision that there's at least some other specified psychotic disorder.
Absolutely.
The more difficult situation is where a person may, as I described before, may come into care for some unrelated reason, or it may be a related reason where they become too wild for their family to handle or whatever, but they're now in care. And it's family sometimes can have a hard time seeing or recognizing, or maybe they recognize, but they don't want to accept what is actually going on in their child's catastrophic loss of judgment. And it falls to a person who's caretaking in like the alternative setting to say, something's really off. Not all the time, but sometimes it's really off. No psych eval. Like is there a process that you like to see the system put into place or get going on so that there is some collateral that comes to you besides kind of act funny sometimes?
So it's a really good question. And I mentioned earlier that, the dream of having the shortest duration of untreated psychosis possible. So I actually have an example of, like, right now I'm currently working with a family and the young person's only 15 and they are only exhibiting psychosis at school, supposedly. And the mom hasn't seen it. The young person is not aware of it. And this is kind of what it looks like early on, especially in younger kids. It's not quite as prototypical as the 18 to 22-year-old who has their first full-blown episode of psychosis. So the best thing that we can do there is they are that person is officially on our radar. Right now, that kid's telling me to kick rocks. There's nothing wrong with him. And there's no clinical collateral. And most importantly, we need a young person who wants to be in our program. So, with that one, we make sure, or I make sure that they have recommendations for support. And I hope that he never comes up on my radar again. But if he does, then we'll be ready, and we know that it was something that was really going on. Now, his duration of untreated psychosis is approximately 4 to 5 weeks. And maybe he is in the prodrome, maybe he's not. But it's best to get him on our radar.
Thanks, I appreciate that. Since it's not in the chat yet, I have one more, if you don't mind me playing Stump the Band.
I'm good.
So families, right? I kind of alluded to this prior. In case anybody in the audience is thinking, well, I have a kid that I'm kind of considering, but the family's never going to go for it. Could you speak to that a little bit?
So, unfortunately, one of the regular occurrences that we see is I'll get a call from a family member who will say, we thought it was something else. We thought he was just smoking too much weed. We thought it would go away. And it's not going away. And it's been going on for 3 years now. What can you do to help me? There's nothing I can do, unfortunately, other than help make recommendations for what they can do. And I promise that I will always do that. But my hands are tied after 2 years. And so this is why we're trying to reduce the stigma of psychosis. The families that I work with sometimes look as though they are in mourning. And it's better to act on it. And a call to us doesn't mean that they have to be in the program. A call to us is just, hey, can you reach out and talk to this family about what your services are, what psychosis is, and whether or not maybe their child or whoever they're caregiving for might benefit from the just the whole array of services that we have to offer. There's no harm at me trying to talk to a family. I don't mind swinging and striking out, but I will, because it's awful when my hands are tied and I can't bring somebody in, and then we have to kind of wait for them to get the hospitalizations to be good for ACT or whatever other kind of program that might be going on. We think of psychosis as a medical emergency, and we act as quickly as we can to try to get somebody in and get them on their way.
Thanks a lot, Dan. It really is a situation where if you're talking to a family, you'd say, what's the worst thing that could happen? You consent to enroll your kid in this program. They get the flagship, highest quality, coordinated mental health care and recovery services available in the county. And so what's the worst that could happen? That Dan's wrong. Their kid's going to get a massive step up in terms of the recovery, whatever you think the problem is. So it's a win-win no matter what. And this kind of a program, the research supports this can turn a kid's life around, which, read between the lines, get them off your caseload before they age out of the system, potentially. And, if we can intervene early, and this isn't going to affect a lot of kids, but when this comes up, the importance of acting quickly just can't be underestimated.
Yeah. Like I have a session like right now with a young person who just got a full-time job. It's amazing. I'm so pumped for them, and it's a Bucks County resident. We've had people graduate from college. Like the stakes are high, and they can go on and they can graduate from Ivy League schools. They can go and travel Europe, like some of one of our young people are doing right now, or just get a full-time job. And so yeah, I appreciate everybody's time. You can email me or call me if you guys have any further questions. Look forward to working more in the system.
So much, Dan, Dr. Siegler, and everyone that joined. If you have any questions for Dan, you can always reach out to me as well. Thanks so much for coming.
Thank you.